First and foremost, I thank Professor Hussain Okasa for giving me the opportunity, and also to the EUS Egyptian Club. It's a big honor for me, and obviously all of us in UAE, are big admirers of Egypt, and obviously Hussain Okasa is there. So today he has given me the opportunity to talk about the role of EUS in mediastinal and lung masses. It's just a short presentation that we need to expand the boundaries of EUS besides the routine indication, which includes the pancreas, the lymph nodes, and obviously the bile duct. So let's see what is the role of EUS in this area. So first and foremost, before we go into the role of EUS in mediastinum and lung masses, we need to understand the anatomy of the mediastinum. So the thoracic mediastinum is the compartment that runs the length of the thoracic cavity between the pleural sacs of the lung. The compartment is divided between two parts, the superior mediastinum and the inferior mediastinum. And the most important part in this is the thoracic inlet. So the thoracic inlet decides superior versus inferior mediastinum. There are no physical barriers except for the pericardium, which divides the inferior mediastinum. So there are four compartments. And if you look at this image, it's basically sandwiched between the lungs and the mediastinal pleura is there. It's divided by a transverse plane that passes through the sternal angle and the lower border of the fourth thoracic vertebra. The superior mediastinum is above this plane and inferior mediastinum is below this plane. So if I look at this image, this classically shows the superior mediastinum, which is at the sternal angle. Anterior, posterior and middle mediastinum is divided by the pericardium. This is another image showing with the vertebra. The T4 vertebra is there. Diaphragm is the lowermost border of the inferior mediastinum. This is another image showing the different blood vessels in the superior as well as the other parts of the mediastinum. This is the image from Gray's anatomy telling us how does the whole mediastinal structure goes. So if you look at the borders of superior mediastinum, thoracic outlet is superiorly, inferiorly is the sternal angle. In anterior mediastinum, it's the sternal angle, posteriorly by the pericardium. Middle mediastinum includes pericardium and its structures, and posterior includes esophagus and obviously the azygous vein. We need to understand the contents of the mediastinum to know the different pathologies. The superior mediastinum is known to harbor thymomas. It includes lymphomas and other etiologies are there. Anterior mediastinum includes thymus and obviously the other arteries are there. The middle mediastinum includes the pericardium and the blood vessels are there. Now again, another image showing the overview. If you look it from the front side, how we divide the mediastinum is there. Now these are the differential diagnoses when we are dealing with the different etiologies. If you see a mass in the anterior mediastinum, these are the differential diagnoses like germ cell tumors, thymoma, lymphoma. If it's the middle mediastinum, we include this etiologies. So these are the differential diagnoses when we look at the different mediastinum. This is another image telling us when we are going through the EUS, through the esophagus, what are the different landmarks, and these are very important when we know that there's a 15 centimeter from the trichopharynx, then 23 centimeter is probably the upper border of the arc of aorta, 25 centimeter the lower border. So these landmarks are important to know where are we even during our routine EUS. This image shows the trachea, the esophagus, and how does the trachea and the esophagus divides the compartment into the right side and the left side, how it divides subcarinal versus the supracarinal regions are there. So I'll be presenting some cases to understand how we can approach such masses. So first and foremost, the first case is a 61-year-old lady with CT chest suggestive of a left lower mass with massive pleural effusion. This patient underwent first thoracocentesis around 2 to 3 liters. They did the sampling. It was inconclusive. There were mediastinal lymph nodes also besides some liver focal lesion. So this is the EUS video showing multiple liver metastasis. As you can see, these are necrotic metastasis because there is a fluid there. And this is the video showing the pleural effusion, which is again anechoic. This is the liver here. And this is the mass, the left lung mass, which we can see a solid heterogeneous mass, which is hypoechoic. and we can use a procore needle or a core biopsy needle to take a biopsy safely without creating any complication, which may include with CT guided biopsies pneumothorax. These are the images of the same patient showing us the localization of the left lung mass, subcarinal region. We know about the station 7, left-sided pleural effusion with the mass, and this is the again the location of the images. This is the AP window lymph node as per the International Association of Lung Disease Classification, station 4 lymph node. This is station 2A lymph node, which is in front of the great vessels of the neck is there. So this is important when we are doing the staging of such kind of cases are there. Coming to another patient, 55-year-old female patient with CT chest suggestive of ill-defined mass, 4 centimeter in the right upper lobe, central in distribution, abutting the mediastinal pleura in the suprahilar region and encasing the right pulmonary artery. These masses are difficult for the radiologist to take a biopsy because of the blood vessels involved. So this is the EUS video of the same patient. As you can see, this is the left atrium, this is the right pulmonary artery, this is the subcarinal space. This is probably a lymph node, but if you see this lymph node is in continuation with the mass here, and this hyperechoic line is the right bronchus, and this mass is encasing the right bronchus. Classically, we can see here with the mass and extension to the lymph node is there. Images of the same patient with the labeling, mass, right bronchus. This is the azygous vein which forms the boundary of the right mediastinal pleura is there, from which we can trace up to the superior border. This is a prevascular lymph node, station 3A lymph node. This is in front of the vessel, and the lymph node which we saw before was the 2L lymph node, which was behind the great vessel. So this is important to understand the classification in the lung cancer patients are there. And this is again the mass with the bronchus. So this is the biopsy which we took in this patient. As you can see, it's a solid hypoechoic mass is there. Obviously, we'll be putting a Doppler to decide, but it's a vascular mass because it's a lung tumor ultimately. So easily we can take a core tissue for the diagnosis in such patients. Moving to the third case, 38-year-old male patient presented with chest pain with significant weight loss. This patient was done this year only in March. A young guy, he had a big mass in the anterior middle and superior mediastinal. This was encasing the trachea 160 degree, the main pulmonary artery, the ascending aorta, the arc of aorta, branches of aorta. So it was a difficult mass. When we discussed with the interventional radiologists, they were reluctant because it was encasing all the blood vessels. So there was a dilemma. He was complaining of chest pain with a significant weight loss, and he was an obese guy. So we took up this case for the EUS. We had a difficulty in pushing the linear EUS scope in the esophagus because of the compression by the mass. But thankfully, we were able to take a biopsy with a biopsy needle. And these are the images of the cells. As you can see, small cells are there. CD20 positive, Ki67. We did the immunohistochemistry on the core tissue. The final diagnosis was diffuse large B-cell lymphoma. Patient underwent chemotherapy with complete resolution of the mass in his latest PET scan, which was done just a couple of months back. He is right now tumor-free with good response to the CHOP regimen. So it was a classical mediastinal lymphoma. Another patient, 31-year-old patient, underwent a CT scan suggestive of anterior middle mediastinal mass with lymph nodes. And this is the CT images of the same patient. As you can see, we are starting from the up with the lungs being seen here. This is the sternum which is coming. We can see a mass, a hypodense mass extending down in the anterior mediastinum. This is the coronal view of the same mass. So easily we can see this is the mass here near towards the right side of the lung. Patient underwent EUS. As you can see, we have done the labeling in this video with the liver being there. And we can see another mass which is different echo texture than the liver. This is the mediastinal mass which we can see here. And it is close to the azygous vein. The azygous vein is always on that side. This is the labeling. The pleural effusion is always on the right side. This is the hyperechoic pleura which is there, and the azygous vein travels near to it. Biopsy suggestive of T-cell lymphoblastic leukemia. It's not a good lymphoma in such kind of patients. with survival rates with only 50%, 5 years. 28-year-old female presented with cough with chest pain, CT suggestive of mediastinal mass with mediastinal lymphadenopathy. Almost similar to the case which I showed just a minute before. We are seeing the liver, we are seeing the inferior vena cava. This is the mediastinal mass which is there, very close to our channel, close to the esophagus. There's no blood vessels around it. It's very close. So paraesophageal mass, we can take a biopsy with a core biopsy in such kind of cases which are there. And it is important that we put a Doppler. We make sure that we are not puncturing a major vessels when we are taking such kind of biopsies which are there. These are the images labeled for the same patient with the effusion and the mass. The biopsy turned out to be a tuberculosis. She was a Filipino lady. She is undergoing treatment for the tuberculosis. So it was an unusual presentation, but we know that in our parts, we do get those kind of patient with tuberculosis. 41-year-old male patient presented with chest pain, underwent a CT scan suggestive of a big mass in the subcarinal area, typical middle mediastinal mass. And this is the EUS of the same patient. As you can see, it's a subcarinal mass, left atrium, right pulmonary artery. But what is unusual for this mass is hyperechoic calcification. So there is a lot of calcification in this mass. It's giving us similar to a if artifact similar which we see particularly in microlithiasis. So those kind of artifacts are there, twinkling artifacts are there because of the calcification in this patient. And you can see the right pleura very close to the mass. Biopsy was suggestive of thymoma. Patient went for a surgery with the thoracic surgeon. And concluding my presentation, this is one paper 2023 giving us a series about the safety of transesophageal EUS guided lung biopsy. If you can see 640 patients, sample adequacy is 95%, accuracy is 94%, and the chances of complication is less than 1%. So it's very safe, particularly in selected patient when the mass is located very close to the esophagus on a CT scan within 2 centimeter. We can easily attempt a biopsy from the mediastinum or the lung masses, and we can give them a diagnosis. So concluding, EUS can be a modality of choice in mediastinal and lung masses, and it can be alternative to interventional radiologists or to the other modalities which include thoracoscopy or mediastinoscopy. Thank you so much for your patient hearing.